Good morning, everyone. I'm Siddhar Jagtap, roll number 120, and I'll be introducing today's seminar on anatomy of lungs to everyone. And this seminar is presented by group members from 106 to 120, along with roll number 88. So, first, I'd like to request everyone to be attentive during the seminar, because firstly, our seminar is really shorter, and secondly, I assure you the guys that if you would be attentive during the seminar, it will be 100% helpful for your exams, and you would not require to carry your mobile phones this time. So these are the topics which we are going to cover in our presentation, and rather than going through boring ChatGPT slides, we are going to include 3 clinical cases in our seminar, all of them being really crazy. And first, this was told to me by Mr. Shal Patel to decide on the dais. So we'll begin with some general anatomy of lungs, followed by fissures, lobes, and then we'll touch upon some embryology, followed by deeper aspects such as bronchopulmonary segments, blood supply, nerve supply. So that was my time, and now I'll invite my colleague Mr. Zaid Sheikh on dais to continue.
Segment का spelling गलत है.
Thank you, Siddharth. Okay, so a very good morning to one and all present here. I am Zaid Sheikh, roll number 111, and my topic for today's seminar is foreign body inhalation and carina. So, case 1, foreign body inhalation. So, before proceeding towards the topic, I would like to discuss this clinical case with you. So, a 4-year-old child was brought to the emergency department casualty of Nair Hospital by his parents. His parents witnessed him swallowing a 5 rupee coin approximately 20 to 25 mm in diameter in his mouth. This was followed by an exaggerated episode of sudden bouts of violent coughing, breathing difficulty, and noisy respiration, shredder-like sound. On examination, the air entry was reduced bilaterally and the cough was triggered immediately during the bronchoscopy when the instrument reached a ridge inside the airway tube. Okay, so before the diagnosis of this case, I would like to introduce you to one of the most important key anatomical as well as clinical landmark, that is carina. Oh, sorry, not this carina.
Hello, sir.
So let us see what is carina.
Hello, sir.
So carina is a cartilaginous ridge located at the lower end of trachea, where it bifurcates into the left and the right main bronchi. It is one of the most important anatomical as well as clinical landmark. So to be precise, it is present at the level of the T4 to T5 vertebrae, and it corresponds to the sternal angle or the angle of Louis, and it lies in the superior mediastinum. So its structure is defined as internal ridge formed with a large tracheal cartilage covered by highly sensitive mucosa.
Sir, सुरू झालं sir. सुरू झालं sir.
It is antero-posteriorly, so it projects posteriorly between the opening of the main bronchi. It is, as you can see in the diagram, it is boat-shaped and shape of a keel. Okay, so if we talk about the relations, so anteriorly lies the arch of aorta and the pulmonary trunk, posteriorly lies the esophagus, and laterally lies the left and the right main bronchi. Okay, so if we talk about the nerve supply, it is supplied by the sensory fibers of the 10th cranial nerve, that is the vagus nerve. And if we talk about the arterial supply of the carina, so it is the bronchial arteries, that is the branch of thoracic aorta. And the venous drainage, it is drained into the bronchial veins, which is further drained into the azygous vein on the right side and the hemiazygous or the accessory hemiazygous vein in the left side. So let us now discuss some questions related to this case. So the first question is, where is the coin lost? So can anybody want to answer?
Can I ask a question?
Yes.
The first slide you started your case with said it is inhalation, foreign body inhalation. Why?
Foreign body inhalation means
Why inhalation?
because it is going into the respiratory tract.
Respiratory. But then you are saying it is swallowed.
Sorry, no, I will. So the answer to the first question is the coin is lodged at carina. You can see in this radiographic film, it's lodged at carina. The second is, what is the anatomical structure responsible for severe cough? So you can see in this diagram that the anatomic structure responsible is also carina, because it is highly it is highly sensitive rich due to presence of mucosa, and it is supplied by the sensory fibers of the vagus nerve. So a slight irritation will also produce a very intensive cough reflex. The third question: why are the symptoms?
Can you just show the coin, where the coin is?
Yes, ma'am.
In the first image also, is that the place where the coin is? That round
Yes.
thing?
Yes, ma'am.
That is not carina.
That is higher up actually. Quite high.
करीनाची जी shadow दिसेल
Is
त्याच्यात
it of the same?
Yes means X-ray of carina we have taken.
तिथं ते बेबी दिसतंय, हे ॲडल्ट दिसतंय.
So the third question is why are the symptoms bilateral in this case? So as we know that the coin is locked at carina, so the coin will obstruct both the airways bilaterally, and it will partially obstruct. So the symptoms, the airflow will be reduced bilaterally, and the symptoms will be bilateral in this case. So what is the clinical importance of this
What is the
structure?
meaning of symptoms bilateral?
Whatever the symptoms would be there, they will be bilateral.
So what symptoms I'm asking about?
I mean, that case
Coughing
starting.
cannot be bilateral.
Yes.
Then
Air entry is reduced
so the
bilaterally.
signs, not
Yes, signs.
symptoms.
Yes, signs.
So here I want to clear one thing. What is the difference between signs and symptoms? So symptom is something which a patient presents with. So the patient will present with difficulty in breathing, breathlessness, coughing. These are what? Symptoms. But when the physician puts the stethoscope and auscultates the lung area, and then he or she finds that there is reduced air entry, that is a sign. So when we say here, it will not be symptom, but the signs of reduced air entry are bilateral. Okay, so symptom cannot be bilateral. Symptom coughing में तो हम दो तरफ से तो नहीं खा सकते हैं, खाएंगे तो
Yes,
एक
ma'am.
ही तरफ से, right?
Symptom signs are bilateral in this case. Okay, so last but not the least, the last clinical importance of this structure carina would be explained to you in the upcoming slides by my batchmate Safwan. Thank you.
Come.
Thank you, Zaid. Good morning to all of you. I am Safwan Sheikh, roll number 112. Today I am going to explain the applied aspect and treatment for the case 1.
एक मिनट, इसमें आपने बताया नहीं स्ट्रक्चर रिस्पॉन्सिबल फॉर कॉफ. आपने क्वेश्चन पूछा है ना वहाँ पे, what causes cough?
Mucous membrane is highly sympathetic fibers, sensory fibers of the 10th cranial vagus nerve. So means थोड़ा सा भी वहाँ पे आपको intense cough.
Okay, so any foreign body or anything solid which enters an airway will trigger a response which is the cough response. And this cough response is protective in nature because your body is now trying to throw out whatever has entered, it is trying to throw out. That is why this cough response is generated. And the afferent is via? The afferent will be via vagus, right? Because the vagus is the one which is supplying the sensory nerve supply. So that is the afferent will always be vagus. And what will be the efferent? Coughing is via?
The whole abdominal, thoracic.
Glossopharyngeal. What causes coughing? Which muscles are involved in coughing?
Anterior abdominal wall. Anterior abdominal wall and
Anterior
thorax.
abdominal wall, yes. And गले में कौन सी muscles हैं? Laryngeal muscles are
Laryngeal.
contracting to give that air explosive effort, and laryngeal muscles are supplied by vagoaccessory
Yes.
complex. Okay, so that, and the more violent effort is by the anterior abdominal wall muscles, and the anterior abdominal muscle is supplied by?
Intercostal.
Question. I am not going to tell you the answer. You are going to find out and tell me the answer. Otherwise, I am going to put it in the exam. Okay. So exam में आएगा ये कि which muscle, what is the nerve supply to the anterior abdominal muscle. So find out. क्योंकि क्या spoon feeding में इधर गया, इधर से गया, इधर से निकल जाता, इधर से गया, इधर से निकल जाता. खुद आप बैठ के पढ़ते हो तो आते. So find out what is which nerve supply the anterior abdominal wall. Okay? I am not telling you the answer.
The applied aspect of carina, number one, cuff reflex. As we know, the carina is a highly sensitive area, which small irritation called the severe
Don't
coughing.
discuss now.
The number two, bronchoscopy landmark. It is an important structure. It is used to identify the tracheal bifurcation, which normally sharp but become blunt in some pathological conditions like tuberculosis, COPD. The number three, foreign body aspiration. As the foreign body inhaled, it usually goes into the right bronchus due to its vertical, wider and shorter nature. The number four, the carina angle. The normal carina angle is 60 to 70 degrees, but it increases in some conditions like left arterial enlargement or mediastinal cyst or tumor.
You have written wider, shorter, more vertical and more in line with trachea, right bronchus.
Vertical means that.
The number fifth, carinal shift, which is seen in pulmonary effusion, fibrosis and lung collapse. Now the treatment for the phase 1, we have to check the ABC of patient, airway, breathing and circulation. After that, we have to check the oxygen support of the patient. If it is necessary, we have to do endotracheal incubation, in which we have to keep the endotracheal tube 2 to 3 cm above the carina point for the proper ventilation of the lungs. After that, the definitive management, which is rigid bronchoscopy, in which we visualize the carina point directly and remove the foreign particle through forceps. Thank you. Now I call upon Sanjana to proceed forward.
Good morning, everyone. Today I am Sanjana, roll number 107, and today I'll be presenting before you the general features of the lung, which is the vital organ for respiration and which lies within the thoracic wall. It is soft, spongy, and elastic.
It lies in thoracic cavity, not in wall.
Before moving on to the general features, let's just see the side determination for the lung. For this, the lung should be held in such a position that the apex faces upwards, the base is downwards, the anterior thin border lies anteriorly, and the posterior wall, which is thick, posterior border which is thick, lies posteriorly. The mediastinal surface along with the hilum should face medially. For the general features, we have the apex, which is blunt. For the general features, we have the apex, which is blunt, and it lies above the anterior wall, above the anterior border of the first rib, and it is covered by the pleural membrane, and it is grooved by the subclavian artery.
Suprapleural membrane.
For the base, the base is semilunar and concave, and it rests on the diaphragm. It separates the right lung from the right lobe of the liver, and the left lung from the left lobe of the liver, the spleen, and the fundus of the stomach. For the borders, we have three borders: the anterior, posterior, and inferior border. The anterior border is thinner, and it is vertical on the right side, and it has a wide cardiac notch on the left side. The posterior wall, which is thicker and ill-defined, extends from the C7 vertebral level to the T10 vertebral level. The inferior border separates the base from the costal and medial surface. For the surfaces, we have the costal surface, which is lined by the costal pleura from one side and the overlying thoracic wall on the other side. For the medial surface, it is divided into two parts: the mediastinal surface, the mediastinal part, and the vertebral part. The mediastinal part is related with the mediastinal septum, hilum and cardiac impression along with the azygous vein, superior vena cava, inferior vena cava, and right
pictures. Image.
Yes, ma'am. It's only next page.
So would you like to show it and show the structures?
Now go on speak.
The azygous vein, the right phrenic on the right side, and arch of aorta, and the left phrenic and left vagus on the left side. For the lobes and fissures, the right lung has 3 lobes and 2 fissures. The superior, superior, middle, and inferior lobe, and the horizontal and oblique fissure. The left lung has 2 lobes and 1 fissure. The superior and inferior lobe and the oblique fissure. It also has a tongue-like.
Can you use the pointer and show the lobes and the fissures? Yes.
The right lung has the superior, the middle, and the inferior lobe, and the left lung has the superior and inferior lobe. Before concluding, the left lung also has a lingula, which is anatomically homologous to the middle lobe of the right lung. Before concluding, let's just see the differences between the left and the right lung. The right lung, which is shorter and broader, weighs 700 grams and it has 3 lobes and 2 fissures, while the left lung which is longer and narrower, weighs 600 grams and it has 2 lobes and 1 fissure, which is the oblique one. Thank you. Now let's learn more about the fissures and lobes from Siddhika.
Hello, good morning. Myself Siddhika Shinde, roll number 118. So my topic is the fissures, lobes, roots and relations of the lungs. Now the fissures of the lung, as we have 2 lungs, right lung and the left lung. So the right lung has 2 fissures, that is one horizontal fissure and one oblique fissure. And the left lung has only one fissure, that is the oblique fissure. These fissures divides the lungs into different lobes. Now the lobes of the lungs. So the right lung has 2 fissures, so it divides the lungs into 3 different lobes. These lobes are the superior lobe, middle lobe and inferior lobe. And the left lung has 1 fissure, so it divides the left lung into 2 lobes. These are the superior lobe and inferior lobe. So as we can see in this diagram, we can see the right lung and the left lung. So 3 lobes can be visible in the right lung and 2 lobes can be visible in the left lung. So So in the left lung, there is a tongue-like projection below the cardiac notch. At the inferior level of the superior lobe, this tongue-like projection is known as the lingula. Now the relation of the lung. The medial surface of the right lung is adjacent to the structures. These structures are the heart, esophagus, superior vena cava, inferior vena cava, azygous vein. And the superior lobe is related to the right subclavian artery and right subclavian vein. Then the medial surface of the left lung is adjacent to heart, aorta, thoracic aorta, aortic arch and esophagus. And superior lobe of the left lung is related to the left subclavian artery and left subclavian vein. Now the root of the lung. The root of the lung is a short tubular collection of a structure that is attached to the lung to the structure in the mediastinum. In this diagram we can see the root of the lung. The root of the lung contains the 2 pulmonary veins, a pulmonary artery, then a main bronchus, then nerves and lymphatics. So in this diagram we can see hilum. Root of the lung contains these structures can be seen. Bronchus can be seen, 2 pulmonary veins which are red color which can be seen. Then a pulmonary artery can also be seen. Then here is a blue color structure which is projecting downward. This structure is known as the pulmonary ligament. So the pleura projecting downward from the root of the lung and extending from the hilum to the mediastinum, this structure is known as the pulmonary ligament. So So that's all about from my side. Now I would like to call Sai Nandini to present the bronchopulmonary segment. Thank you.
Good morning everyone. Myself Sai Nandini Bhatkar, roll number 106. So my topic is bronchopulmonary segments. Before that, let's see a case related to this. So a patient, a 38 years old male, arrives at the OPD with dyspnea, that is difficulty in breathing, cough, fever and hemoptysis, that is blood in sputum. So history shows patient is a chronic sufferer of tuberculosis infection which manifested about a year ago. The standard 6 months antibiotic course did not work as intended as the infection was multi-drug resistant. So the treatment for the same was started, but the patient has responded poorly. So investigation shows a chest X-ray revealed consolidation and cavitation in the apical part of the right superior lobe. Rest of the lung tissue appeared relatively unharmed. So here we can see the consolidation in the apical part of the right superior lobe. So a lobectomy of the right superior lobe was recommended by the thoracic surgeon on consultation with a pulmonologist. So how can you only remove a part of the lung? So the answer to this question lies in the anatomy of bronchopulmonary segment. So what are the bronchopulmonary segments? These are the smallest functionally independent region of the lung and the smallest area of the lungs which can be isolated without affecting the adjacent regions. So these bronchopulmonary segments are anatomical, functional and surgical segments. So regarding their shape, they are irregular cone shape with their apex at origin of segmental bronchus and their base towards periphery, that is on a surface of lung. Regarding their supply, each bronchopulmonary segment is supplied by a segmental bronchus accompanying a pulmonary artery branch, and we can see the tributaries of a pulmonary vein intersegmentally. There are 10 bronchopulmonary segments in each lung, and some of the bronchopulmonary segments in left lungs are fused. So here we can see the bronchopulmonary segments in the right lung and bronchopulmonary segments in the left lung. So now let's see the names of bronchopulmonary segments using this 3D model video. So here in the right lung, as we know, there are two fissures, horizontal fissure and oblique fissure. Therefore, three lobes: superior lobe, middle lobe, and inferior lobe. In superior lobe, we have superior anterior, superior apical, and superior posterior segment. In the middle lobe, we have medial and lateral segment. In the inferior lobe, we have anterior basal, lateral basal, superior, posterior basal, and one more, that is medial basal segment. In the left lung, in the superior lobe, we have superior anterior, superior apical posterior, and in the lower segment of the superior lobe, we have superior lingular and inferior lingular segment. In the inferior lobe, we have anteromedial basal, lateral basal, superior and posterior basal segments. Thank you. Now I would like to call Shreya Wankhede with her further presentation.
Why have you shown anterior and medial fuse?
3D video.
In the left lung,
Why?
they are fused.
Why? You have shown anterior medial fuse. No? Okay. No. Homework, huh?
Good morning everyone. My name is Shreya Sanjay Wankhede, roll number 119. So for today's seminar, my topic is blood supply and nerve supply of the lungs.
केस खत्म हो गया या केस अब आएगा उसका अब आएगा
Lungs have dual blood supply via pulmonary circulation and bronchial circulation which serves as two distinct functions. In pulmonary circulation, the deoxygenated blood from right ventricle from heart goes to the lungs for purification, and in bronchial circulation, it is the nutritive supply for the lungs. Now let's see the pulmonary circulation in more details. The right pulmonary artery and left pulmonary artery originate from the pulmonary trunk. The bifurcation of pulmonary trunks occur at the level of left to the midline, just inferior to the vertebral level of T4 and T5, and anteroinferiorly at the level of bifurcation of trachea. Now let's see the relations of the right pulmonary artery and left pulmonary artery. Right pulmonary artery anterior relations are ascending aorta, superior vena cava, upper right pulmonary vein. Posterior relations are tracheal bifurcation, right main bronchus. Now let's see to left pulmonary artery. Anterior relations are superior pulmonary vein and posterior relations are descending aorta. Now pulmonary veins. These pulmonary veins carries oxygenated blood from lungs back to the heart in left atrium. On each side there is superior pulmonary vein and inferior pulmonary vein. These veins begins at the hilum of the lungs, then passes through the root of lungs and then in the left atrium. Now let's see the bronchial circulation. Bronchial arteries, these arteries originate from the thoracic aorta or one of its branch. Single right pulmonary artery originates from third posterior intercostal artery, and two left bronchial arteries originate from the anterior surface of thoracic aorta. Superior from the vertebral level of T5 and inferior to the inferior of the left bronchus. Now bronchial veins. These veins drains into left atrium or azygous vein on the right side and superior intercostal vein on the left side. As you can see in the diagram, this is pulmonary trunk which bifurcates into left pulmonary artery and the right pulmonary artery. Now let's see the innervation of the lungs. Lungs and the visceral pleura are supplied by visceral afferents through anterior and posterior pulmonary plexus. This plexus further divides into sympathetic and parasympathetic supply. So sympathetic supply is by sympathetic chain which functions as bronchodilation and vasoconstriction, and the parasympathetic supply is through vagus nerve which functions as bronchoconstriction and vasodilation. Now let's see the lymphatic drainage. The superficial lymphatic and the deep lymphatic of the lungs is via lymph node which called as tracheobronchial nodes, which extend from lungs then through the hilum and root and then goes into the posterior mediastinum. That's all from my side. Now I would like to call Shalva Patil with his further presentation.
What about the distribution of the blood vessels in relation to the bronchopulmonary segments? Is it coming now?
No, she just passed a remark. एक रिमार्क पास की आर्टरी अंदर होती है,
वेन
इंटरसेगमेंट अंदर डायग्राम भी नहीं था.
So for all of you, when you are attempting any question regarding the bronchopulmonary segments, apart from giving the definition and it is aerated by a segmental bronchus, you have to say that the pulmonary veins are intersegmental and the pulmonary arteries are segmental. Please make a note of that. Bronchial artery is also coming in the center, but pulmonary veins are intersegmental, and that is important because they are used as a guide, as a landmark when you are doing segmental resection of the lung. So the surgeons pass along these, they go along the pulmonary veins, and that's how they know that this is one. नहीं तो वहाँ पे कोई map नहीं बना हुआ है. The map is the pulmonary veins का how they line intersegmentally. Okay, so that is important. और उसी में आपका जो question था in your it will come into that. Okay.
So good noon everybody. Am I audible to all of you? Am I audible now?
Yeah.
So our patient needs a lobectomy. Let's see what that is. For that, as ma'am mentioned, we need to understand bronchopulmonary segments. So each bronchopulmonary segment has one arterial supply, one bronchial supply, which means each of those will act as a segment inside the lung. And essentially, if there is any pathology in them, it stays confined to the segment. If it affects a bunch of segments at once, then it stays contained inside the lobe. So if we need to remove that pathology, we can do something called segmentectomy for a single segment, lobectomy for an entire lobe. Pneumectomy is you remove an entire lung. Wedge resection is somewhat similar to this. I wouldn't say it follows exactly the same procedures or principles. It is done mostly when you need to biopsy or in very early stage cancers. So when do you perform a lobectomy? Firstly, obviously our patient is a TB patient, so for TB, lung abscesses, lung cancers, especially the non-small cell lung carcinomas, which have a tendency to be more localized, and fungal infections. Oh yeah, and
tuberculosis infection.
yes, like
All.
no, like first some specific cases where it has stayed contained inside one segment, we can remove that segment or a lobe.
Resistant cases.
Yes. On a side note, the right superior lobe of our patient is infected, right? So why does tuberculosis have this tendency to only affect the apex of the lung? Not only, but predominantly. Anybody? Yes, please. Okay. That is right. Tuberculosis is an aerobic bacteria, and the apex of the lung being poorly circulated, the oxygen will stay there, which will create a high oxygen pressure in the area. So what do we consider before getting the surgery? Firstly, lung function tests. Then things like cardiac assessment and blood work is like almost compulsory for any other surgery. Lung function tests are very important here. Reason being, imagine this, you have a patient, you remove a lobe, then you realize that the remaining lung is unable to compensate for the lost parts. So that should not happen, right? Hence, we need lung function tests. So what are the different surgical approaches? Firstly, the most traditional one is thoracotomy. So, consider this to be the vertebral column. This is the sternum. And these are the ribs. I will not be drawing all of them. So because we have to go to the apex, we'll choose the upper intercostal spaces for this. Now in an intercostal space, we need to make a cut. Where do we make the cut? The lower border of, the lower border of the upper rib, upper border of the lower rib, or right in the middle? It's a question. Okay, why? Right. So in the subcostal groove of every rib, there will be a neurovascular bundle. To preserve it and not cause any injury to it, we need to make a cut safely below. The next thing, once you have made the cut, is you use something called as a retractor, where you essentially you pull the ribs apart, like to make an opening. And then you, from that opening, you will approach the lung, remove whatever part you want, and close up again. Now, okay, this works, but what are the problems with this? Firstly, you are making a very big incision. Next, you are separating the ribs using force, so it's a bit crude. Anything else you can think of? Sorry? What is the direction of the fibers of external intercostal muscles and internal intercostal muscles? is the external intercostals, and this will be the internal intercostals. So when you make this cut, you are cutting a lot of muscle fibers. This will take time to heal. So it is not the most efficient form of surgery. So what do we do now? With advancements, we have something called video-assisted thoracoscopic surgery. This patient is not being tortured. This is the standard procedure. So what you do here is you make small incisions through which you insert cameras and other instruments inside. So essentially you can go in, cut the part of the lung which you want to, and pull it out. You can visualize it very well with the thoracoscope. And lastly, the robot-assisted thoracoscopic surgery. Yes, I was going to ask that. It's the Da Vinci robot, named after Leonardo da Vinci. He was also an anatomist and made one of the first robots, so for him. This is a comparison between thoracotomy and VATS or RATS, as I'll be calling them now. So I'll be making a comparison here. VATS and RATS are like Gen Z, and thoracotomy is their parents. Parents are firstly simple, cost effective.
They are better.
I'll be coming to that. But they are also more inefficient. Then the surgery takes more time to heal. VATS and RATS, Gen Z. More expensive tastes. Also more efficient. But whenever there are complications with Gen Z, we have to turn to parents. So our patient was he had funding, he had insurance, so he could choose VATS, and the surgery was a success. I had to put him in, sorry.
Are you Mr. Bean fan?
Okay, thank you. That will be all from my side. Now, to study post-operation recovery and changes, I would like to call upon my teammate Shirin Sheikh. Thank you.
Good afternoon everyone, my name is Shirin Sheikh, roll number 113. So from the previous presentation we know what lobectomy is. It is a surgical process in which one lobe of the lung is removed. So after the surgery, there are some precautions that should be maintained in order to avoid any further complications. So in this preventive measure, there are some phases that should be followed. So the phases included are hospital phase, early recovery at home phase, rehabilitation and long-term recovery phase. So the first phase which is hospital phase, which lasts from the day one it says when the surgery takes place to the 7th day. This includes the immediate post-operation, which held in ICU, where patients wakes up with chest tube, intravenous lines, and an incentive spirometry. Pain management, which is a crucial step in this phase, in which patient control analgesia, which is a pain control drug, is given to the patient. Pain control drug is mandatory for deep breathing and coughing. Chest tube management, which helps in the removal of the air and fluid in order to help the lung to expand to fill the chest cavity. The next one is incentive spirometry, which helps to encourage the deep inspiration.
Incentive intensive.
Incentive spirometry.
What is that?
Incentive
Intensive
with a C?
or T.
Oh, sorry.
What?
See.
Incentive spirometry, what are you trying to say by incentive? That you are giving an incentive to do spirometry, or are you doing an intense spirometry?
Incentive spirometry.
Incentive spirometry.
Okay.
Just check that.
You'll
See
have to
that.
clarify
I'll
this.
Whether it is
Check that.
incentive or intensive.
Intensive.
Okay, I'll check that. So the next phase, which is early recovery at home, it includes pain and wound care. The patient may feel numb, sore, or itchy at the incision site, which is normal. Fatigue. The patient may experience extreme fatigue, which can last for months. In shortness of breath, the patient experiences breathlessness while doing a mild activity, as the lung requires time to expand to fill the chest cavity. In lifestyle restriction, the patients are advised to not lift the heavy object more than 5 kg, as this can help to prevent the hernia at the incision site, and this can accompanied by daily activity. The next phase is rehabilitation and long-term recovery phase, which lasts from 2 to 6 months. Breathing adaptation, return to work, pulmonary rehabilitation, and follow-up are included in this phase. So again, in lobectomy, one lobe of the lung is removed, right? So does this mean the lung loses its function? The answer is no. The lung does not lose its function, but it actually tries to compensate. And this compensation is known as the lung enlargement. The lung enlargement after surgery refers to increase in the volume of the remaining lung tissue following thoracic surgical procedures such as lobectomy. It plays a crucial role in maintenance of adequate ventilation and oxygenation in post-operative patients. So, compensatory lung enlargement. This occurs after removal of lung tissue. The remaining lung expands to fill the chest space. This improves gas exchange. As we can see in the first picture, where the two lungs are present in its anatomical position. But after the surgery, the right side of the lungs is expanded because the left side of the lung is removed. So due to this, there is the expansion and mediastinal shift of the right side of the lung. In the next picture, which is a CT scan image, the heart is present in its anatomical position. But after the removal of the left side of the lung, the right side of the lung pushes the heart towards more left side, which is the mediastinal shift towards the operated side. For example, as we can see in the picture, there is a deviation of the trachea from its anatomical position. In this picture, the right side of the lung is removed. So, as a compensatory enlargement, the left side of the lung pushes the trachea towards the right side. So, there are the changes in the lung. Structural changes and functional changes. In structural changes, alveolar enlargement is seen. Increased lung compliances and mediastinal shift. In functional changes, improved ventilation, which is perfusion making, and increased tidal volume are seen. So this was all from my side. I would like to call upon the Shatrughan to explain the next topic.
Very good afternoon to all. Myself, Shatrughan Singh Rajbura, roll number 115.
जो लोग सो रहे हैं जग जाओ. This is an important topic. Okay, this is your UG level topic, so you should know. So please wake up, whoever, or if you are doing your journals, please stop doing that. Listen to what is being told here. Good.
Today, me and my teammates will be presenting a case on pleural effusion. The case is a 52-year-old male presents to the OPD with progressive shortness of breath for 2 weeks. The patient reports gradual worsening of breathlessness over 14 days. Chest pain increases with deep inspiration. Chief complaints are dyspnea, initially on exertion, now at rest also. Right-sided chest pain, dull and non-radiating, dry cough, low-grade fever and fatigue. No history of hemoptysis. He has also noticed mild weight loss and reduced appetite. Treated pulmonary tuberculosis 10 years ago, no known cardiac disease. He is a chronic smoker. The investigations are on X-ray of chest, the homogeneous opacity in right, lower zone blunting of right costophrenic angle, ultrasound thorax, moderate pleural fluid collection, management, anti-tubercular therapy, standard 6-month regimen, therapeutic thrombosynthesis for symptomatic relief, supportive care, analgesics, nutritional supports.
Before you change 1 minute, everybody see the X-ray. See the X-ray clearly.
Show the claustrophrenic angle.
Show the claustrophrenic angle and how the claustrophrenic angle on one side is present and there it is obliterated.
Blunted, yeah.
That is a very big sign of pleural
Show
effusion. Okay?
everyone. Which side is affected?
Claustrophrenic, phrenic. ये dome of the diaphragm जहाँ यहाँ से dome जा रहा है, इसका एक corner पे यहाँ. This angle and see there. It is not clear. It is obliterated. So an obliteration of claustrophrenic angle is a very big indication that there is a pleural effusion happening over there.
Firstly, let us know what is pleura. Like the peritoneum, pleura is a serous membrane which is lined by mesothelium. There are two pleural sacs, one either on the each side of mediastinum. Each pleural sac is invasionated from its middle side by the lungs. So it has two layers, the outer layer parietal pleura and the inner layer the visceral pleura. The space between these two layers is called a pleural cavity, and this cavity is filled with the thin layer of the pleural fluid. Now let us see what is pleural effusion. Pleural effusion is an abnormal condition. It is an abnormal and excessive collection of fluid in the pleural space, which causes lungs to constrict and causes problems in the respiration. Normally the pleural fluid is entering in the pleural space through the capillaries in the parietal pleura and get removed by the lymphatics in the parietal pleura. The pleural effusion may be due to the excessive production of the fluid or reduced absorption of the fluid. The pleural effusion occurs due to an underlying disease process which could be related to respiratory system or could not be related to the respiratory system. That could be related to other systems also. Commonly, the pleural effusion occurs in these diseases: pneumonias, malignancies, pulmonary embolism, tuberculosis, congestive heart failure. That's all from my side. Now, I would like to call others in there for mechanism and types of the pleural effusion. Thank you.
Thank you, Shatrugna. So hereby I will continue. Good afternoon to everyone. Myself Patru Shinde, and hereby I will continue with my topic, that is mechanism and types of pleural effusion. So let's begin with the topic. So first of all, I would like to tell what are the mechanisms of pleural effusion. Mechanisms of pleural effusion are the ways through which the pleural fluid accumulates in the pleural space. So there are primarily 6 mechanisms of pleural effusion. First is increased hydrostatic pressure, second is decreased oncotic pressure, third is increased capillary permeability, fourth is impaired lymphatic drainage, fifth is movement from peritoneal cavity, sixth is decreased intrapleural pressure. So let's discuss briefly the mechanisms so that it will be helpful in understanding the types of pleural effusion. So first is increased hydrostatic pressure. What does hydrostatic pressure refers to? Hydrostatic pressure is basically the pressure which is applied by the fluid on the walls of the capillary. So as you can see in the diagram, the hydrostatic pressure pushes the fluid into the pleural space, so it contributes to the accumulation of pleural fluid in the pleural space. Then we have the oncotic pressure. Oncotic pressure is basically the osmotic pressure which is due to the proteins present in the capillaries. So the proteins present in the capillaries create a suction pressure which pulls the fluid into the capillaries from the pleural space. So these two mechanisms are also called as Starling forces. Then the third mechanism of pleural effusion is increased capillary permeability. So in normal cases, the endothelium is intact and the tight junctions are also intact. So there is limited movement of the fluid. But in cases of inflammation and injury, the endothelium is damaged, so there is free movement of the fluid across the capillary. So it results in accumulation of pleural fluid. Then we have another mechanism which is impaired lymphatic drainage. As Shatrugna said, lymphatics are the mainly responsible for the removal of pleural fluid from the pleural space. So if lymphatics are damaged due to malignancy or any obstruction,
then the pleural fluid is accumulated in the pleural space. Then we have the movement from peritoneal cavity. It occurs in cases of ascites. In ascites, the excessive accumulation of pleural fluid is there in peritoneum. So the accumulation of fluid creates the passage of fluid due to the pressure from the peritoneal cavity to the pleural space through the small defects in diaphragm. As you can see in the diagram, there is direct passage through the defects in the diaphragm. Then we have the last mechanism, which is decreased intrapleural pressure. It occurs in the cases of atelectasis, in which the lung is collapsed, so it creates a suction or vacuum effect which pulls the fluid from the capillary. So these were the mechanisms of pleural effusion. These will be helpful in understanding the types of pleural effusion. So the pleural effusion is classified primarily and secondarily. Primary classification is mainly based on the mechanism through which the pleural effusion takes place. So primary classification is transudate and exudate. Transudative effusion is when the Starling forces are altered. Starling forces are basically the hydrostatic pressure and the oncotic pressure. So when they are altered, the transudative effusion takes place due to increased hydrostatic pressure or decreased oncotic pressure. It is caused in abnormalities like congestive heart failure, cirrhosis, and nephrotic syndrome. Then we have the exudative effusion. Exudative effusion takes place when there is damage to the pleura due to inflammation or injury. So the mechanism here is increased capillary permeability, in which the capillary endothelium is damaged, or the lymphatic drainage, impaired lymphatic drainage, in which the obstruction of lymphatics take place. The causes here are pneumonia, malignancy, and pulmonary embolism and tuberculosis.
If anybody is watching anything on phone or is being distracted by phone, either you go out of the class, do whatever you want to do there. Whoever is sitting here will not be playing on the phone. If I take it, you will not get it till tomorrow.
So the secondary classification is mainly divided on the basis of etiology and the fluid which is accumulated in the pleural space. So the first is parapneumonic. It is based on the etiology, in which due to pneumonia the accumulation of fluid takes place. Second is empyema, in which it is based on the fluid which is accumulated. So there is pus formation in the pleural space, which is basically the infected fluid. Then we have the hemothorax. It is based on the fluid accumulated. In this case, the blood is accumulated in the pleural space. Then we have the chylothorax, in which the thoracic duct is blocked, which results in accumulation of chylomicrons and the triglycerides in the pleural space. Then we have pleural effusion due to malignancy, in which the cancer cells are detected in the pleural fluid. Then another classification which is based on tuberculosis is tuberculous pleural effusion, which is due to tuberculosis. The chronic granulomatous inflammation takes place in the pleural fluid. Then we have the serous pleural effusion, in which the clear pale yellow fluid is accumulated in the pleural space. So this was all about the types. Now I would like to call Ashutosh Sawant to present on the diagnosis of pleural effusion.
Good afternoon all. My name is Ashutosh Sawant. I am here to present the diagnosis of the pleural effusion. As Shatrughan presented with the case of the pleural effusion, now we further move on the diagnosis of the pleural effusion. When the patient comes in the OPD, during the history we can find some signs such as the dyspnea. The dyspnea is due to is the difficulty of the breathing. The difficulty of the breathing is due to the restriction of the lung expansion. Then we can see the pleuritic chest pain. The pleuritic chest pain in the initial stages is very sharp due to the friction between the two pleura, that is parietal and the visceral pleura. And in the later stages, it decreases due to the accumulation of the fluid in the pleural spaces.
Which pleura is pain sensitive?
The parietal pleura is pain sensitive due to the very highly innervated by the nerve. Then there is a dry cough seen. The cough is dry due to there is any infection inside the lung. It is outside the lung in the peritoneum, parietal
Mic जवळ घे.
in the parietal space. So there is no formation of the mucus in the lungs, and there is no sputum seen in the cuff. And the cuff is due to the as the pleural the fluid is present in a pleural space. So there is a decrease or the constriction of the lungs, and which causes the cuff reflex to. Then we further confirm the findings of the history through the physical examination, also called as the bedside confirmation, in which we can find the reduced chest movement on the affected side, and on palpating we can see the decreased tactile local parameters. In the tactile local parameters, we palpate the vibrations on the chest wall in the intercostal spaces, and the decreased tactile local parameters is due to the accumulation of the fluid in the pleural space, which absorbs the vibrations and causes the decreased tactile local parameters. On percussion, we can find the stony dullness. In normal lung, there is a resonant node seen on percussing, but in the case of the pleural effusion, due to the accumulation of the fluid in the pleural space, we can see the stony dullness on auscultation. On the auscultation, we can find the decreased vocal resonance for the same reason as the tactile local parameters decreased because of the pleural fluid present in the space. And there is a decrease or absence of the breathing sound according to the amount of the fluid present. Then we further confirm our findings of the physical class examination through the radiological confirmations. First, we see the X-ray of the patient. In the X-ray of the patient, there is a blunting of the costophrenic angle. What is the costophrenic angle? It is the angle between the ribs and posterior cartilage and diaphragm. And in that image, we can see the costophrenic angle, which is a sharp in the normal lungs. And in the case of the pleural effusion, we can see the blunting of the angle in the pleural effusion. Then we can see the meniscus sign. What is the meniscus sign? It is the concave surface at the upper margin of the pleural fluid, which is accumulated at the lower borders of the lung. And also in the massive effusion, we can see the mediastinal shift as mentioned by the shearing shape. Then for the further confirmations, we do the ultrasound. What is the need of the ultrasound? The X-ray can confirm us that only the pleural fluid is present in the pleural space. But what the volume of the pleural fluid is present, where it is actually present, and what should be the probable site for the thoracosynthesis is given by the ultrasound. Also, the ultrasound can detect us the very small amount of pleural fluid, and we come to the CT scan after a while. Then, after doing the ultrasound, we can determine the probable safe site for the thoracosynthesis. So, what is the thoracosynthesis? It is the procedure by which we aspirate the pleural fluid and diagnose it, analyze it. The probable site for the thoracosynthesis in the 7th, 8th and 9th intercostal space in mid-axillary line. And after doing the thoracosynthesis, we come across the various components of the pleural fluid, and depending on that, we can distinguish between the two types of the pleural effusion as mentioned by my colleague Atul Shinde. The transitive and exudative type of are distinguished by measuring the lactate dehydrogenase and protein levels in a pleural fluid. There is one criteria called as Light's criteria, which helps to distinguish between the transitive and exudative type of pleural effusion. The exudative type of pleural effusion meets the following. The ratio between the pleural fluid protein and serum protein is greater than 0.5, and the ratio between the pleural fluid lactate dehydrogenase and serum lactate dehydrogenase is greater than 0.6, and pleural fluid lactate dehydrogenase more than the 2/3 the normal upper limit for the serum. There is one difficulty in this criteria is that this criteria misidentifies the 25% of the transitive cases as the exudative cases. For further accurate diagnosis, we measure the gradient between the serum protein and the pleural fluid protein, and if this gradient is greater than 31 gram per liter, then we can accurately say that this is due to the transitive type of pleural effusion. And after doing the thoracosynthesis, we are not certain about the cause of the pleural effusion. Then we do the CT scan for the seeing the different causes of the pleural effusion, such as the malignancy and or Then there are some peculiarity distinguishing factors between the different types of the pleural effusion. In the cases of the effusion due to the heart failure, there is a generally bilateral pleural effusion, and we can measure the N-terminal pro-brain natriuretic peptide in the pleural fluid. What is the pro-brain natriuretic peptide? It is synthesized by the left ventricle as a result of the overstretch due to the overload and through the hydrostatic pressure which is increased during the heart failure. As my colleague referred the hydrostatic pressure, it comes to the pleural fluid and can be detected in the pleural fluid, and if its quantity is greater than 1500 picogram per milliliter, it can be diagnosed as the effusion due to the heart failure. In the hepatic hydrothorax, the patient has a history of the chronic liver diseases and also the alcohol consumption, and we measure the serum protein, serum and pleural albumin gradient, and in the chest X-ray we can see the right-sided pleural effusion, and ultrasound of the abdomen shows the ascites and the cirrhosis. Then in the parapneumonic effusion, the X-ray can show the pleural effusion and the underlying lung consolidation. In thoracosynthesis, we can see the decreased pH below the 7.2 due to the production of the lactic acid by the bacteria, and in the glucose levels are less than 60 milligram per deciliter due to the due to the consumption of the glucose by the bacteria. The lactate dehydrogenase levels are very high, and the cell count is predominantly contains the neutrophils. Then, in the cases of the malignancy, we can see in the CT scan the pleural thickenings, pleural nodules, and lung masses can be seen, and in the pleural fluid we can see the malignant cells. Then, in the tuberculosis pleuritis, fever, weight loss, and night sweats are seen, and small lymphocytes in the pleural fluid. We can diagnose the tuberculosis pleuritis by TB markers such as adenosine deaminase, and in the chylothorax we can find the milky pleural fluid and the presence of the chylomicrons and the triglycerides in the pleural fluid greater than 110 milligram per deciliter. Thank you. I would like to invite Pranshu for further explanation.
Good morning everyone, myself Pranshu Kamble, and today we will be going to discuss upon how the pleural effusion is actually treated. Coming on to the goals, why should the pleural effusion be treated? It is to relieve the symptoms such as dyspnea and discomfort, to treat the underlying cause, which is that the fluid is accumulated in the pleural membrane, and to prevent the recurrence of fluid in the pleural membrane. What is the initial approach? The initial approach is to assess the severity using clinical and imaging, and then to identify the cause based on the fluid analysis, and then to decide need for urgent drainage. Now coming on to the process that how the pleural effusion is actually treated. There comes a patient with pleural effusion, then we would be assessing symptoms using imaging and X-ray vision to check whether the patient is symptomatic or asymptomatic. If the patient is asymptomatic, then we should observe and treat the underlying cause, which could be another than pleural effusion. And if the patient is symptomatic, then we could perform thoracentesis, which is both diagnostic and therapeutic. And then we would analyze the fluid using Light's criteria to distinguish, to judge that the pleural effusion is transudate or exudate. If the fluid accumulated is transudate, it may be due to the pressure changes such as oncotic changes, oncotic pressure difference, and if the pleural effusion is of exudate type, then it may be due to the inflammation. The cause of transudative effusion is heart failure and liver cirrhosis, and of exudative effusion is infection, TB, and malignancy. Now coming on to the definitive management, means what is the primary management that we should do, what are the primary things that we should do to manage the pleural effusion. As discussed earlier, there are two types of pleural effusion, transudative and exudative. The transudative is mainly due to congestive heart failure, liver cirrhosis, nephrotic syndrome. The heart failure and liver cirrhosis may be managed on primary level using the diuretics and the salt restriction, and the nephrotic syndrome could be managed by treating the underlying kidney disease and to manage the protein intake. Coming on to the exudative effusion, it may be due to infection, which could be treated by antibiotics and drainage. It is tuberculosis, which could be treated by anti-TB therapy. It could be malignancy, which could be treated by chemotherapy and radiotherapy. It could be pulmonary embolism, which could be treated by anticoagulation. Coming on to the prevention and advanced care, the pleural effusion could be prevented by treating the underlying cause such as of kidney, heart and liver, and to maintain a healthy lifestyle. Coming on to how the pleural fluid is prevented reoccurring, there are three types. First is pleurodesis. Pleurodesis is a procedure to obliterate the pleural space so fluid cannot reaccumulate. Its outcomes are it prevents reoccurrence and improves the quality of life. Coming on to second is indwelling pleural catheter. It is a long-term tube placed in pleural cavity for intermittent drainage. Its advantage is that it could be managed at home and it reduces hospital visits. Coming on to surgical management, it is used when the both pleurodesis and IPC is failed or there is a chronic disease. It includes decortication and pleurectomy. The following is a flow chart which summarizes all of these. That if the person has pleural effusion, we should identify the cause and differentiate it between transudate and exudate, and then treat the underlying cause, and then drain the fluid. And if the fluid is recurrent, then we should do pleurodesis, and if it also fails, then we should do surgical management. Coming on to the supportive care. Supportive care is always given along with the definitive treatment, such as oxygen therapy, which relieves hypoxia, nutritional support, which is important in TB and malignancy, and physiotherapy, which improves lung expansion. Thank you. That's all from my side. Now I would like to call upon Sanskruti Raut for further discussion.
The key take-home message that how is pleural effusion drained, what is the procedure called, in which intercostal space is it performed, and what part of the space is it performed. That is your anatomical basis for which you are here. So ये तो तुमको आना ही चाहिए. अगर ये नहीं आया एग्जाम में, yes, this is all very high level, which will be useful as you study next year. जब तुम pathology, pharmacology इसे पढ़ोगे, medicine पढ़ोगे, surgery पढ़ोगे, उसमें ये सब आएगा. लेकिन ये जो चीज़ है, what is most important is what is thoracocentesis or what is pleurocentesis, in which intercostal space it is done, and what part of the space it is done, and why are you doing that, and even अगर जब आप उसको नीडल जब जा रही है तो कौन सी लेयर्स को पियर्स कर रही है, ये इतना आपको एनाटॉमिकल बेसिस आना चाहिए, घर जाके पढ़ना ये. ओके
Good afternoon everyone, I am Saraswati Raut, roll number 108, and now we are going to explore the embryology of lungs, which is not just about the growth and development, but also about the precise partitioning and splitting. So the process begins in 4th week of intrauterine life as the laryngotracheal groove appears on the ventral pharyngeal wall. As the groove deepens, a midline evagination from the foregut called respiratory diverticulum appears. The caudal end of the respiratory diverticulum grows downwards and enters thorax to form the two lung buds, and the cranial end of the respiratory diverticulum forms laryngotracheal tube, which forms the future larynx and trachea. these are the tracheoesophageal folds which grows medially and fuse to form the tracheoesophageal septum, hence it separates the trachea from the esophagus. These two lung buds further divides into the right and left bronchi. These right principal bronchi forms into three lobar bronchi, and the left principal bronchi forms into two lobar bronchi. Further, in 7th week of intrauterine life, this lobar bronchi splits to form the 10 segmental bronchi, which corresponds to the 10 bronchopulmonary segment. The pink portion we can see in the last image is the lung parenchyma, which is formed by splanchnopleuric mesoderm of the lateral plate mesoderm. Next comes the maturation of the lungs, it is a process of change in morphology and histology within the lungs. It is divided into 4 phases, which is pseudoglandular, canalicular, terminal sac stage, and alveolar stage. The pseudoglandular stage occurs in 6th to 16th week, where the bronchi divides up into terminal bronchi. There is no respiratory portion formed, and the lung resembles the exocrine gland, which is also tubulo-acinar gland. As the distal, we can see the distal part of the. So we can see the distal part of the lining epithelium, which is a cuboidal epithelium. It does not support the respiration or exchange of gases. Next comes the canalicular stage, which occurs from the 17th week to 26th week. Here, the 16th to 26th week. Here, the terminal bronchi further divides, the lumen of the terminal bronchi increases. It further divides into respiratory bronchioles, the alveolar ducts, and few alveolar sacs are formed. Here, the capillary network increases. The next comes the saccular stage. In the saccular stage, we can see the distal part of the bronchioles, where the primitive alveoli is formed. Here the cuboidal epithelium becomes flat and thin, converting into the type 1 pneumocytes. There are also differentiation of type 2 pneumocytes, where the surfactant starts increases. So even if the fetus is born in this stage, can be viable and can survive on intensive unit. Next comes the alveolar stage, which is from birth to the 8 years of life, where the alveoli is more developed, more matured, the number of definitive alveoli increases, as well as the surfactant secretion increases, the capillary networks also increases, and overall the gas exchange occurs. So for the applied aspect and developmental anomalies of the embryology, I would like to call Shireen Hafiza for
You get a full question on lung. You get full question on lung, where the morphology, then the development, the histology, and the applied aspect. So here this histology or the development, histology to bhi kya nahi, but our development is also important. So please study this. This is important for you. Okay.
How many generations are added? You said up to 8 years of age.
I don't know much about the alveolar, but what I know, the tracheobronchial tree is divided up to the 16th generation.
Any adult, how many generations?
I don't know about
Homework.
Good afternoon, everyone. Myself Sheikh Hafiza, roll number 110. As Sanskruti have discussed embryology of lungs, I will be presenting applied aspects related to lung embryology. So, first case is tracheoesophageal fistula. As we know, during 4th week of development, when the two tracheoesophageal folds form tracheoesophageal septum, which separates trachea from esophagus. When the tracheoesophageal septum fails to form properly, there is a connection between trachea and esophagus. There is a connection between trachea and esophagus, which is called as tracheoesophageal fistula. It leads to esophageal discontinuity, that is called as esophageal atresia. Incidence is 1 in 3000 births, and it is also a component of vectoral anomalies. Vectoral anomalies is a group of anomalies which are vertebral, anal, cardiac, tracheal, esophageal, renal, and limb anomalies. There are various types of esophageal atresia along with or without tracheoesophageal fistula. So first is type A, where the upper portion of esophagus forms a blind pouch and the lower portion of esophagus connects with trachea, forming tracheoesophageal fistula. This occurs in 90% of cases. Type B, where the tracheoesophageal fistula is not seen and both upper and lower portions of the esophagus form blind pouches. Type C is H-type tracheoesophageal fistula and there is no esophageal atresia seen. And type D and E are rarely seen variations. Clinical features seen in tracheoesophageal fistula are excessive oral secretion, respiratory distress, choking, coughing and cyanosis on first attempt of feeding, and inability to pass the nasogastric tube, and there is polyhydramnios, that is excessive amniotic fluid in mother because the neonate is unable to swallow amniotic fluid, and complications like aspiration, pneumonia and pneumonia are there. Also the chances of gastric content entering trachea through the tracheoesophageal fistula are there. Next case is infant respiratory distress syndrome. As we know, after 26 intrauterine life, after 27th week of development, the type 2 pneumocytes, that are simple cuboidal epithelial cells, forms lung surfactant. Lung surfactant decreases the surface tension between the air and liquid, and they prevent collapse of alveoli. So when there is when a preterm baby is born, there is no sufficient lung surfactant, so the alveoli are not able to open sufficiently, and the baby is not able to take the first breath. Okay, so and it was previously called as hyaline membrane disease because the damaged alveolar cells form hyaline membrane. Pathophysiology is like lung surfactant decreases, surface tension increases, and therefore alveolar collapse, that is atelectasis happen, and therefore impaired gas exchange is there. It is a major cause of neonatal mortality as it accounts for approximately 20% of total neonatal deaths. It can be managed by giving artificial surfactant therapy, and glucocorticoids can be given to mother. Next one is ectopic lung lobe. During 4th week of development, as the respiratory diverticulum grows from the foregut, and extra respiratory diverticulum is formed, which causes ectopic lung lobe. It develops independently of main lung, and it has.
Go to the next one. We have got very less time. There is another class. Go to the next one.
Okay. The other congenital lung anomalies like pulmonary agenesis, pulmonary aplasia, and pulmonary hypoplasia are there. Pulmonary agenesis, where the complete absence of lung tissue, bronchi and pulmonary vessels are seen. It is usually unilateral. Pulmonary aplasia, where the blind ending rudimentary bronchus is there, and functional lung tissue and vasculature is not. It is differentiated from pulmonary agenesis based on bronchoscopy, and pulmonary hypoplasia, where the underdevelopment of lung tissue, bronchi and vessels are seen. They exist, but they are smaller and fewer in number than normal. And now I would like to call Chetan to give us a small summary about today's.
Good afternoon, myself Chetan Shijwal, roll number 116. I will presenting summary for this topic. First one is a foreign body inhalation. Foreign body inhalation occurs when object enters the airway. It is mainly seen in the right bronchus of the lung, and symptoms of this condition is coughing, choking and wheezing of the lungs. And ideal treatment for this is bronchoscopy, where removal of foreign object by the surgery. Second is the general anatomy of lung. The lung present in the thoracic cavity which are separated by the mediastinum. The right lung has 3 lobes while the left lung has 2 lobes. And the primary functions of the lungs are the gaseous exchange. Third one is the bronchopulmonary segment and lobectomy. There are 10 bronchopulmonary segments in the right lung, while left lung has 8 to 10 bronchopulmonary segments. Lobectomy, it is a surgical procedure to remove one lobe of lung in case of tumor. Pleural effusion is simply the accumulation of fluid in the pleural cavity. It is mainly caused due to the TB and cardiac heart failure, and the symptoms for this pleural effusion is chest pain. The last topic is developmental aspect of lung. The lungs develop at the embryonic leg from the respiratory diverticulum. The development of lung occurs at various stages like canalicular, pseudoglandular, alveolar, and embryonic. Thus, the lungs are vital organs for the respiration, and understanding its anatomy and development is important for accurate diagnosis and effective treatment. I would like to call Shalvo for the vote of thanks.
Okay, we are short of time. All of my teammates, I would like to call you on the stage, please. We have taken 20 minutes extra today. We are very sorry for that. We thank you for your patience. Thank you to Simanal, Sachin sir, Datta sir, and Jayanand for. Special thanks to Rahul sir. I would also like to call him. Thank you. Special thanks to anatomy department also, who has given us the opportunity to present our seminar. And very special thanks to our all batchmates who have been sitting very long and attended our seminar. Thank you.
Okay, they deserve a round of applause because I'll tell you what all I liked about in the seminar. Number one, that they included clinical cases. So that was one good aspect because you have to correlate everything clinically. So that was one very well presented seminar. Number two, their slides were very nice and neat. So that was also a good point. Number three, all of you spoke very well. You knew your subject, you had learned very well, and you presented it very well without any hesitation. So this is the first platform that you are speaking, and this platform, if you have done so well the first time, then I'm sure you are going to do far better in the future. So give them a round of applause for this. The drawback which I felt here, I am going to state it so that next time the teachers who are also guiding can keep in mind that you should restrict your material to what is relevant to the first MBBS curriculum. You can have a little nice to know content which is not exactly here. So like the mechanism of production and all was very good. The advanced care part, the days of recovery and all that, that becomes a little overwhelming at your stage. So you can have more, I would say, have more emphasis on what is relevant to this year or this, because abhi aap log ka clinical exposure hai nahi. So it becomes a little difficult when you're talking about treatment and especially अभी next year आप जाओगे pharmacology and pathology जब वो पढ़ते हो तब all the relevance comes into context, but अभी इतना नहीं है. But anyway, it was very nicely presented. बहुत ज़्यादा नहीं करके, it was still simplified. But what happens is that in the whole course of presentation, somewhere if something is too overwhelming for us, then we lose the attention of the audience. So this is not for you. This is mainly for the teachers who are guiding, that have it as much relevant so that it is sticking to the point and they learn what is more required at this age. Okay? So very, very well done. Very good. Go ahead.